everyone. Thanks for joining today. Our webinar tonight, we're talking about CO2 lasers. And my name is Dr. Jeff Rohde. I'm really excited to be doing this with you tonight, especially um, with so many great things that I would love to show you. Tonight, we're specifically talking about expanding your practice with a 9.3 micron CO2 all tissue laser. Um, when this laser first came out, I think the misconception at the time was, and not misconception, but the understanding of it was that this was a great laser to truly do anesthesia-free cavity preparations. But for our practice, it's really done so much more than that. And so I want to I'll show you a little bit of the cavity preparation, but I really want to focus 95% of the night on just how much more we've enjoyed doing with this and how it's actually kind of helped grow our practice in terms of that. And really the encouragement here as we go through things, I don't want this to be the kind of thing where it's kind of like the Jeff Rohde show. I want to kind of start to help you think about your patients, your practice, things you're comfortable with, where you might get out of your comfort zone a little bit and start using a tool that's unlike anything else we have in our arsenal. Because that's the thing, what this laser does, and we'll go into this a little bit, but what this laser does essentially is basically, it certainly does anesthesia-free cavity preparations, and not all the soft tissue surgery and things that I'll show you are anesthesia-free. We might certainly use some numbing or topical anesthetic in these cases, but it has unparalleled cutting. It cuts better and heals faster than anything else we have on the market available to us for surgical procedures today. So that's kind of the difference of CO2. And that's what I want to inspire you with. So as we start going through these cases, kind of think of, exams you've already done this week or cases you have coming up and how you might actually utilize the technology for that. So, I hope to meet all of you at some point. For those of you I haven't met, I'm Jeff. I have a practice here in Santa Barbara in California, and went to UCLA for dental school. And basically, the thing for us has always been to utilize technology to provide an unparalleled patient experience. And one of those things for us, certainly the latest thing in the last several years, has been the 9.3 micron CO2 laser. And that's the thing. We have basically a laser that can do and cut, and we'll go into this a little bit, but anything biologic in the mouth. It'll cut bone, it'll cut anything soft tissue, that thick connective tissue behind the second molar, it's going to cut that, right? And it's safe to use around metal, and we'll kind of go through all that. But really, the whole concept here is that we're able to truly be all tissue, and we'll go into what that means. Oftentimes I kind of get asked, for all the technology we have, and just to kind of briefly go through this part, it's like, well, how do I know, like, why do I care? In other words, why does this matter? Why does this become something that I would want to invest time and energy on? Why would I want to kind of upset my team to bring on something new? We just switched practice management software about a month ago. Boy, that is an example of making sure we really have the vision for why we're switching, because it's such a hassle, but worth it in the end. And I kind of often go through these 4 different things. And I kind of go, okay, well, of those things, what am I looking for? Well, and this is for really any product, but really, if I'm looking to incorporate new technology, I at least want it to be more efficient, kind of create efficiencies within the office, either to get more done during the day or to have a better patient experience from a more efficient procedure. And that's the thing for us, is 90% or greater anesthesia-free, blood-free as it cuts through, is a huge thing. I can work in multiple quadrants, no problem, because we're not necessarily numbing up. A cavity preparation for a typical like class 2 for for an adult might be 2.5 minutes. For a pediatric tooth, it might be 60 seconds. And that's all it takes. So we have marked efficiency is simply because, we're not numbing to start for some of those hard tissue restorative procedures. Now, of course, that creates a great story. So it'd be wonderful if the technology I invested in also allowed me to have basically a nice grassroots word of mouth marketing program behind that. And that's certainly what we found is when we're creating a great experience like that, people like to talk about it. The other thing is then, and this is where we'll focus on today, is um, newer procedures. What am I referring out? Like if I had a way to do a certain procedure better or as good as the specialist I'm sending it to, and potentially even have better outcomes compared to traditional methods, isn't that going to be something that maybe would be worth getting involved in and keeping those procedures in house and expanding the breadth and depth of what we do in our practice? One of the things I'll be showing you today is a sleep application that's new in the last couple of years, and I'm also sneaking in a new thing that is literally not even out yet, but you're going to get to see as a little sneak preview tonight. It's a new flapless perio handpiece used for flapless perio surgery. So I'm going to give you a little sneak preview of that toward the end. And that again, that's not even out yet, but I'll be able to show you a lot of the research and background that has gone into that. It's an amazing new tool. Again, it's going to grow our practice and expand what we do in that way. So, and then of course, I just feel like anything we do can't compromise. Nothing can be gimmicky. It has to actually clinically work and create a great clinical outcome, and that's not something that can be compromised on. That has to be there. So and for us, Celea has really certainly done that in terms of the ability to do just kind of these like kind of pillar of four things that I think we need before we invest in anything. And like I said, you could apply that to anything, but specifically as far as the laser goes, this has really kind of altered the entire dimension of our practice. Um, so just for those of you who haven't seen this before, or just a question on how any laser works, you can look at a laser as basically being a flashlight, right? Any light you shine on anything will either pass right through it, think sunlight through a glass window, or reflect off, think sunlight on a mirror, or absorb in, like if you hold your hand out in sunshine and it feels warm, your hand is absorbing some of that energy, right? And so we know that there's different interactions that laser or light energy has. Well, one way then we look at the way lasers cut. I wish it was more like a lightsaber, but it's a little more, in some ways, more simple than that. And that is the absorption. So if I, put a steak under a restaurant heating lamp, that steak is going to be warm because of absorbing that infrared energy, the infrared wavelength from that heating lamp, right? And so if I want to cut something, if I want to cut any tissue or sheet metal or concrete, I need to make sure that that substance is actually absorbing that energy to a point of ablating that thing. So let's look at an example of that. So if we follow along here, on here, we can kind of see my mouse pointer there. You see where there's a blue line here. Across the bottom, we have wavelengths. So this is shorter wavelengths like UV up to visible spectrum, all the way up to infrared, going all the way to your right. And then up this direction on the y-axis, you see where there's actually absorption of that particular wavelength. And so if we look down in this area with the blue line, this is kind of the visible spectrum. What the blue line represents is the absorption of water, or the wavelength by water. And so you can see, hey, if I shine visible light at water, it doesn't absorb very well. But look all the way over here, there's this huge peak absorption for water that, in this case, when we shine that wavelength, kind of where erbium lasers fall, when you shine that wavelength at water, water just wants to so very much efficiently absorb that it literally the water molecule itself ablates, rips apart, vaporizes, however you want to say it, and then that is how it quote cuts. So when you start to look at how some of those erbium lasers work, it's not really doing anything to the tooth structure as much as it fires a beam down, finds that water molecule on the surface of the tooth from some water spray or from the 1% to 2% of water that's in tooth structure. It ablates that water molecule and then essentially blows up that water molecule and blows chunks of tooth structure away. So it does that kind of slow and more like collateral damage. Now compare that kind of to the green line, which is hydroxyapatite. And here's where the CO2 laser that we're talking about today lands. Right here at the 9.3 micron wavelength is where the peak absorption for hydroxyapatite is. So the way this laser works is you essentially fire a beam down and never mind the water, it finds hydroxyapatite, which is 85% or so of enamel. The hydroxyapatite absorbs that and then ablates the hydroxyapatite. And so in that way, it's not necessarily an explosive cut. It's more like what it looks like is you're directly dissolving away tooth structure, right? And I'm going to show you a little video that kind of shows that. Um, so that's what we call the target tissue for this particular laser. Now it also works here at a little secondary peak for water. So part of the reason it cuts soft tissue is it also cuts water, but not so explosively as erbium lasers do because it's a little bit off that peak, right? And so, of course, cell structure being mostly water, in this area right here is where we'll see that it actually um, will cut sort of quote cut soft tissue. Now, one of the best things about this is that when it cuts, there's no bleeding involved. So how does that happen? Well, one of the other things about the laser is that essentially it goes just deep enough, the absorption into that tissue is just deep enough that it actually absorbs into collagen and the collagen actually contracts. So imagine cutting a straight line through tissue, and on either side of the cut, collagen is shrinking down and closing off blood vessels and lymph vessels to create more of a coagulation effect, which then keeps the blood from just basically bleeding during the procedure. Now, I actually have a video of this kind of effect. One of the things that with the laser is when we do training here in Santa Barbara, we actually will have pig jaws for doctors to use to practice different perio procedures, crown lengthening, surgical incisions, fibroma removals, frenectomies. So we'll practice all that. And one of the pig jaws I was using at one point was just kind of drying out a little bit, but still had enough moisture left to kind of show a nice cut. And this video, although it's a little bit gross, I got to admit, is basically the floor of the mouth of the pig jaw. The green dot is the aiming beam of the laser. You can't see the 9.3 micron beam, so there's a little green dot to show where you're actually going to be cutting. And what you're going to see is basically collagen contracting toward the center of the beam. And essentially what this is kind of answers the question, well, how come it doesn't bleed when it cuts? It's because it's basically condensing down that collagen there. So here it is basically kind of moving along. You can see at positions even far away from the actual center point of that aiming beam that you see it's pulling collagen in, right? So pretty incredible effect from that. Now, this gets into it a little later when we talk about the Celea sleep and talk about how we treat snoring and treating the soft palate. Just kind of put this video in the back of your mind because this kind of shows why that effect works too. So just to put a little context around there, let's kind of look at this video. What you'll see is a little decay, some old composite resin. It also, side note, also cuts composite resin just amazing by ablating the resin component. So what you'll see is the first thing I'll do is actually go in there and remove um, some of the soft tissue there as we come across. And it's just kind of resculpting that. Now, definitely, one of the things we cover in training too is to kind of be aware of what, how much attached tissue you have left. There's a different technique if it's thin, so you do want to pay attention to where the keratinized tissue is. But you can see how there's a nice smooth cut there, no bleeding whatsoever. And then we simply turn the laser toward the tooth and start ablating away. And the nice thing is with this laser is you don't have to worry about changing the setting. That 9.3 micron beam gets absorbed into hydroxyapatite, decay, soft tissue, composite resin, and can handle ablating that. Now, obviously, and you can see that there. Now, one of the incredible things about this is that tissue is basically only 3 days later, and that kind of shows essentially how fast that healing actually occurs. Now, when it's cutting through, I am moving around different tissue, and we have dense enamel where we're creating a bevel, and then we have a little less dense composite and much less dense decay, and I'm kind of moving in around those. One of the difference with this CO2 laser with Soleil is it actually has a variable speed foot pedal. So this is the actual screen that I see every day. I can change spot size to be small beam or wider beams, right? I can change how much water's coming out. We really don't change that, but I can change cutting speed, how fast or slow it cuts. This is essentially a measure of power. But once I have that set, then I basically use this foot pedal, which is very similar to the foot pedal that you have in your operatory already. And if I want to cut slow with a handpiece, I just push lightly on the foot pedal. Or if I want to cut fast, like I'm cutting a crown, then I'll press harder. Well, this is exactly the same. So there's a lot of intuitive crossover to what you're already doing with your normal handpiece with that. And so I can kind of feather that power and just sculpt lightly tissue like you saw, or I can, push harder and really, prep out a class two. It's really easy after that. So, um, um, so, um, take home lesson here. I don't have to understand joules and hertz and watts and fluents. I just turn it on, select the size you want, and it's going to cut. So pretty fantastic there. And that's the thing, with new procedures, I could start doing things that I didn't do before. New revenue procedures. I mean, this kind of opens up the door to things like in the CDT codes in the 4,000s, the 7,000s even if you're in network for certain plans that generally have better negotiated rates because they're surgical procedures, right? And that's the benefit to you. This is new stuff. It's different. It kind of invigorates the day, but the benefit to the patient, I'll give you one example with crown lengthening, for example. Normally, at least what I was taught is you want to give it at least 6 to 8 weeks of healing. And with this, basically, I'll show you a case where we basically went to the final restoration in one day. And I would expect final healing within a week. So we're talking about a week or less healing in time from actually bony removal, crown lengthening type procedures compared to 8 weeks. And the benefit to the patient, it's then their primary provider who's doing it, and they don't necessarily have to go to another office if you're already doing this. So let's get into then some of the procedures that we do. Um, by the way, there is going to be a Q&A at the end. If you open up your little Q&A tab there and you can type in questions, I am kind of monitoring some of the questions coming in. So as you kind of think of stuff, go ahead and type in the questions. We are going to have about 5 to 10 minutes at the end to kind of go through that too. Um, okay, so let's start talking about some of the actual. So that's how the laser works. That's how you control it. Very intuitive, very straightforward. Now, what am I going to do with this thing, right? And so the first, most easiest thing I do is essentially a de-epithelialization. So the first videos you saw there, we had some water going and spraying as it cleaned off that tooth. This is basically kind of a dry cut mode. And what I use this for is any kind of mucositis or lichen planus, aphthous ulcers. Basically, you're cutting kind of dry. And what we're doing essentially is almost kind of creating a laser band-aid. But in the case of lichen planus, you're not limited to the size of an aphthous ulcer like I'm going to show you. You can hit the whole interior portion of their cheek. The idea being you're almost hitting the reset button on that tissue. You're stimulating healing, you're creating flexibility and making it easier so they can eat. So here's basically an aphthous ulcer that we did where it's hard to tell from the video because it's washed out a little bit, but this was fiery red. It was so fiery red that some of those little areas, as we kind of crossed over them, almost kind of had a little bit of a oozing effect because we weren't spending too much time on that. But you see where it's just kind of essentially kind of sort of really kind of hitting that top level surface. And that's the thing about the lasers. You can do one cell layer at a time, or you can bomb through enamel for a class 2. Both are all based on how you're using your foot pedal, right? Now, what is the benefit to this patient? Well, again, with those super puffy edematous areas, that's going to help basically contract that collagen down. It's going to basically make it so they can eat. This is like putting a laser xylactin down, and it'll stimulate healing. So this will be gone in about 48 hours or less. So great benefit for that. So that's one of the easiest things, right? It's like a very mild surface ablation. One question that just came in, what CDT code do I use for that? Basically, you can either do it as a palliative treatment or destruction of lesion. That's another one that we'll use sometimes. Sometimes we'll even kind of bury it in a 0140. Just kind of part of the exam because as you saw, look how long this takes, right? To do that. And then another question that just came in, is it good for perio therapy? Yes, and I have a whole perio section I can't wait to show you. So stay tuned for that in just another maybe 15 minutes or so. By the way, I love it when it's live because we get these live questions that come in, and I wish I was all here directly with you guys, but here's one question that came in, and I love the discussion of this, right? Here's the question: Can a laser accidentally damage more tissue or teeth, like how it happens with a drill, where you accidentally nick or pulp perforation or tissue laceration? Here's the good news. So I will often encourage people that this is safer than a handpiece. When I was cutting that tooth, you actually have to hold it there, and you notice my hand was moving pretty slowly. So if you happen to glance away at tissue, it's gonna do this. The most it's gonna do. Yes, Josh Smith is going to be recorded. It's so you can watch it again. They'll have it on the View Learning site. So the most it's going to do is do this maybe to tissue if you even see it, especially if the water's going. So you have to actually intentionally hold it. Like if I'm going to do a frenectomy, I have to hold it there. And if I move my hand too fast, it doesn't allow the laser energy to gather up and it doesn't cut. And so that's the benefit of using this laser. If you're doing a class 2 and the patient swallows and you accidentally move part of that beam onto the adjacent tooth surface, it's going to, what it's going to look like, if it even registers, as long as you don't hold it there, um, it's going to look like basically you had like a little phosphoric acid, like a little blue etch on that surface, and that's it. Versus if you hold it there, step on the gas, and intentionally cut with great control, you're going to cut very fast. So there's very it's almost, unless you are not paying attention, it's almost impossible to have any ancillary damage to teeth around it. Um, and then just one more quick question here, then, of course, um, is there any heat generation like pulpitis? Interestingly enough, that was a question they had to answer for the FDA to get FDA approval. So they literally had a tooth, fired the laser at the tooth, and embedded in the tooth was a little thermometer that they had to show that it wasn't increasing. So that's kind of a misnomer of CO2 lasers, that you're burning up pulps. Absolutely not. That's never happened. No one's ever gotten a root canal because they used this laser. If anything, there's water spraying. The video I just showed you had no water. If anything, the water that's spraying down on the tooth is helping to cool the tooth as well. So if anything, what I prepare the patients for to do anesthesia-free dentistry is I say, hey, this is the great part. No numbing, no drilling today. Rah, rah. Um, what you will feel is a little cold, from the water kind of spraying down on the tooth, and that's it, right? Because I want them to know that they'll feel a little bit of that washing effect, not unlike you finish up a teeth cleaning and you're rinsing off the pumice, kind of like that. So pretty amazing with that. So, okay, so that's back to the presentation there. That's kind of the easiest thing it does. Now, if you use back to that smaller spot size, if you use a smaller spot size, this is where it kind of cuts more like a scalpel, like a diode laser would. Problem with the diode is it's more heat based, so really you're kind of just melting tissue rather than truly ablating tissue. So we use this for things like a crestial incision for an implant, a biopsy, vestibuloplasty. I'm going to show you a case of these things coming up here. But that's the idea, is you narrow the beam down and then that gives you a nice little straight line cut. So here's a frenectomy we did on a patient in his early 30s. And so we'll start to kind of cut down there. He was already putting some nice tension on that tissue. So basically just kind of cut straight through. I go all the way down to the floor of the mouth. I don't have to continue too much farther than that. And we'll do a little revision on those little extra tissue tags and just kind of smooth it out. So I can do everything from cut fast to do a little, like over here, I'm just going to actually hit those fibers and do a little sculpture to smooth that out and get the extra tissue taken care of. And this is where, like, what's the technique here? How hard is this? Gosh, I haven't done surgery since dental school. Things like that kind of question comes up. Um, um, basically, it's really, a matter of you point it at it, it's going to cut it. And you can see in the video, I'm starting to have them do some exercises here to stretch out to kind of determine how much more I need to laser. But you basically stay in the middle for safety. Don't go to either side of the tongue where the lingual nerve or lingual artery is. Um, um, and then basically just kind of stay in the middle. Now, the question just came up, is anesthesia done during this? I think with this one, we did a compounded topical. Again, back to kind of what we talked about at the beginning, the big idea with restorative procedures is that with teeth, I can do things anesthesia free. When it comes to surgical procedures, kind of the rule of thumb there is the deeper I go, the more likely I might need some level of anesthesia, right? The big idea being that I have something that cuts better and heals faster. Like this frenectomy is going to be healed in about 2 or 3 days, right? So, and no bleeding, easy to do it. The technique is simple. I'm pointing at it to cut it, right? So Now I believe I added it this afternoon, showing you an extraction case where in that case, I'm going to be elevating root tips. Now that patient's numb, but I'm using the incredible cutting and then post-op healing from the laser to get the job done. So that's a huge part of it. Um, Let me just make sure I got to that question on that one. Um, okay. Okay, back to another question. So why doesn't it hurt that much, unlike surgery? Well, if I'm cutting through like a big, and I'll show you a vestibuloplasty in just a minute here, it is a deep cut. It would hurt, right? Again, comfortable anesthesia free is more teeth restorative procedures, but surgical procedures, I will do an infiltration. We try to do topical. In this case, I just used a little compounded topical lidocaine, tetracaine, phenylephrine. Um, Push that gel in there partially because I need to put a little tension on that fibroma. So I'm going to pull on it. And here I'll start playing it just for time here. But as I pull on that, you know, just the tissue forceps are going to be tender, right? And so what I'll do is I'll start going through and as I pull on that, and I always have to give myself a hard time because it looks like my hands are shaking in, but the microscope is just at a funny angle. But just pulling on that could be a little tender. So we go to the level of maybe a little topical anesthetic. Now, for the next case that I'll show you here, and then again, back to technique, right? Um, one real quick, one question that came through, is there any odor from the cutting? Nice part there is no. It doesn't smell like you're burning tissue, especially because you're ablating tissue. Now, it was a bigger fibroma, so I got a little bit of bleeding there. And so I just kind of paint back over with the laser and that kind of mops that up and causes that coagulation to stop that. So here's a question that came in from an existing user. I've used Soleil a few times in soft tissue, but have had bleeding. Is this a spot size or a power issue? One of the things that you saw there is if the blood vessel is big enough, so this fibroma had been there long enough that it actually had some accessory blood vessels growing in there. And the vessel was wide enough that the initial lower power of the laser wasn't enough to cause coagulation. And so I kind of went back and painted over there, and that was enough. But if you have, if something's already puffy and bleedy and, you just kind of look at it and it bleeds kind of thing. One example would be you have a person who lost, interproximal filling, and now they're just packing food and packing food and packing food, and all the tissue's puffy and red, and it bleeds just when they brush it with a toothbrush. That is going to bleed irregardless of whether or not you're using the laser. Now, the great thing though is that you can use the laser then to sculpt that tissue back down to healthier levels and kind of paint that away. But generally, if I see bleeding, it's because there is already usually some inflammation going on with that. So hope that helps to kind of troubleshoot that. Okay, so here's that vestibuloplasty I was talking about. The reason why we're doing this is it's hard to tell from the video just from the angle, but right across here, this is the base of his vestibule. Like over here where you like store your gum, over here, and there's like a little pocket, a little vestibule by the cheek. There's nothing, right? And so right here, you see where there's actually a tissue attachment, with that's actually causing recession here. So just for time, I'm going to speed this up into where what we'll do is we'll start actually kind of lasering through there, and I do a little frenectomy at the time and then start pulling away. And what you're doing here is actually, and you can see where there's a little water in there too. What I'm doing is actually putting tension on the lip. Imagine pulling the lip away from the chin, and your working angle is essentially dissecting the lip off the chin. And I'm excluding that keratinized tissue, which will allow me to basically let that sit and over time, over the natural course of healing, it'll help boost that up. So again, for time, let me kind of fast forward. That's immediate post-op. We don't need to suture. You see where it's kind of been irritated just from me pulling on there, but then let's go to the 1 week healing. Here's what it looks like after only 1 week of time. Now look across there to where all this tissue is already healing. And if anything, I'm already getting a little rebound in that tissue as that comes back. Um, um, and then let me jump forward to, I think I have 2 week healing time. So here's 2 weeks, and there's a little bit of plaque on there, but here's after 2 weeks of healing time, right? Now the question then is, okay, is this stable? And this video is basically about 3 years after that. Um, so here's the same patient 3 years later. You see how that tissue's rebounded. There's a little bit of tension below it, but not on the actual gingival line angle. So as you start to kind of think about your patients coming this week, we just avoided all kinds of trouble and grafting and perio procedures and potential more recession on that tooth by being able to do this procedure. So tomorrow, when you're doing all your hygiene checks, all your periodic exams, every patient, kind of sometimes it's like, well, my gosh, when am I going to see any of this stuff? Well, admittedly, I didn't see it until I started doing it and knowing what the limitations or advantages of this tool was. And so I would encourage you tomorrow with all your hygiene patients that you're doing checks on, just look down there, pull their bottom lip out. You're going to see someone like this, right? Who has this going on. So that's my encouragement for you. One quick question that came on. What is post-op care instructions? I actually have them. I'll usually send them with either chlorhexidine, or if they don't want that, salt water. It is a little sore, but I'm not sending them home with any narcotics of any kind. And then with that, they will actually do some exercises where they'll kind of push their tongue down in there to keep it away. I've tried perio pack and stuff like that. It doesn't really help. It just kind of gets in the way. So just kind of have them sort of stick their tongue down in there a few times a day to kind of push on that. Post-op instructions with the lingual frenectomy is, imagine, push your tongue out, lick the buccal of the upper right molar, lick the buccal of the upper left molar. I mean, you just want to kind of create that movement so that you don't get any relapse with that. Another question that came in, patient on blood thinners, will this laser help for soft tissue procedures? It's not in this presentation, but I have a Coumadin patient that I did a double crown lengthening for a bridge preparation on a couple broken teeth. And absolutely the answer is yes to that because of that. Now, side note on that, I would still, we still consulted with his physician to make sure things were stable enough to do that, but I don't pull people off of blood thinners to do these procedures at all. Okay. Just kind of, I'm going to try to get in as many cases as I can and keep answering these questions. I'll let this kind of play out, but this is the kind of case where you have a couple root tips in there and you're like, okay, you go to grab it with the forceps and they just crumble, and so it's like, okay, I got to go in there and get that. Well, I can go in there with the laser and just basically remove the bone around that tooth, kind of hog in there, get that going. And be able to go in there with that. I'll just kind of let this play out and answer some questions while we're going. So what are the contraindications for the patient? We have all these other things, right? Like blood thinners or pacemaker, or, it's basically there isn't any. Even for a patient who's pregnant, we have a laser that is operating in the infrared range, right? So I don't have to necessarily worry about radiation, where we wouldn't want to do an X-ray. No question, I can just basically go in there. And here, I'll just skip forward a little bit where now I have a leverage point. So I made a little troughing so I can actually get in there and pull that out of there and start working on that. So excellent for extractions. I think I have another one here that I lasered around, and you can get a little purchase point and actually create a little leverage in there to start getting that out. I've had broken root tips where I was able to remove bone around the broken root tip, um, as well as look at I always laugh. My assistant's getting there to help. So yes, this patient was numb for this extraction. Absolutely to get in there. Again, using the laser as an essential tool for what we're doing, even though if I'm going to stick an instrument in there and pull on that root tip, absolutely, they're going to need some numbing for that. Um, is there back to that previous one? Is there any concern that you may damage the tooth when doing a lower frenectomy? Not to answer that question, I think a little more simply, Ryan, is basically don't point it at it. You have absolute control. You follow that aiming beam. And so it's not like you get side damage, you know, your question of iatrogenic damage or going too deep. You really have to hold it incorrectly, like point it at the wrong spot on the tooth. The other trick there is my laser energy when I'm doing those frenectomies is always down the long axis of the tooth, not pointed toward the tooth, if that makes sense. So I don't have anything pointed toward a root surface that could actually um, cause that problem. So, okay. Other things you all might see, anatomic crown lengthening here. We have this broken cusp, all this tissue grown in. Now what, right? Definitely this is where I like to have that laser on and ready to go. Um, um, so in that case, then I start to kind of remove some of that tissue, get the prep done. Now I know exactly where I need to go, and then start removing that tissue and actually getting some of that tissue removed. And then, of course, we go even a little deeper for our biologic width. And then in this case, we went straight to the final restoration and adapted the back of that Emax crown to sort of fill anatomically. Couple quick questions here coming in. Do you wind up with any dry sockets? So again, by the way, this is an example of closed technique for crown lengthening where I'm not creating any new pockets. I'm lowering the level of bone to account for biologic width, at least 2 millimeters below the margin. Very simple, very straightforward. Do you wind up with any dry sockets after using the laser? Absolutely not. And the reason is because you're ablating, but you're not heating, you're not charring. You know, you're basically cutting the surface of the bone, but compare that with something that had friction or like the way a diode laser cuts with heat. Absolutely, I'm worried about dry socket, but not with this. In fact, this makes doing your degranulation of the extraction socket simple. I've even used this for, you get a little broken root tip. I can trough the bone around the root tip, or I can shoot directly into the socket and laser away the final parts of that root tip because it'll ablate away the actual tooth structure. And then you can clean it up that way. So very, very simple to do that. Question from Aaron. So then am I using, going back to this case, right? Am I using a traditional handpiece? Yes, there's some onlay preps that I've done with the laser, no problem. But for a larger molar like this, where I need to create a particular shape and a chamfer style for the restoration material itself, I'm doing the actual preparation. So this patient's numb, right? Or if I'm cutting off an old PFM, I'm going to numb for that. But then I have this incredible tool to use for the actual soft tissue work with better healing. And again, in this case, I was able to go to the final restoration right away. But Aaron, to your point of your question, very often, like I will use, because this is an end cutting device, I will often use a side cutting device like a handpiece to break a contact, refine the prep, just kind of cheat with that side cutting device, no problem at all. When you're cutting a tooth, it's also creating um, basically it's also creating um, an analgesic effect as it cuts that tooth. So it's no problem like on a class 2 to do like a little polish up with your handpiece. So I will often use a handpiece, because that analgesic effect carries on for 7, 8 minutes. So you have this open raw class two, and they're perfectly comfortable to me doing my bonding steps, right? Air, water, dry it, put the bond on, adapt the flowable, whatever you're going to do, they're totally fine. Um, so uh, uh, to that point, then the question comes, can you cut crowns off with this laser? Uh, yes, on Emacs, it does okay. Yes, on zirconia, it actually breaks the zirconia apart. No on PFM, no on gold crowns. It's not going to cut through metal, right? So in those cases, I might still be using, the good old-fashioned handpiece for that. Okay, so those are some more extreme and deeper cases. But another method that I have in here is I can actually do tissue sculpting. Um, there's um, there's the capability to do crown lengthening, like I said. That's more of a sculpture scar revision. I'll show you that case if we have a little time. But here's a case where basically I'm just doing an aesthetic gingivectomy. Um, and just sculpting that. And I have it on a nice low power, and it's more than just cutting. Someone asked the question of like, how do you not hit the tooth? Look, we just talked about this a minute or two ago, where you can actually see the sculpture of that gum tissue, but I'm not hitting the tooth at all. Partially the reason is I'm just going at an angle where it's not going to hit it. Partially the reason is it takes such little power to cut that tissue that to cut tooth, I'd have to have it at a higher power with that foot pedal. So very, very easy to control. Um, um, Back to the analgesic effect, it was a question on, does it remove amalgam? So no, it won't cut the amalgam, but I do rely on the analgesic effect to basically kind of, for all intent purposes, shut those nerves down. And then and then when it basically then as we go through there, I could pull out the handpiece and cut that amalgam out, no problem. Um, again, just kind of seeing some of the sculpture happening there. And again, look at the lack of bleeding happening. Now, a milder version of that is just using this for some of your traditional or digital impressions. Kudos to Dr. Tim Anderson up in North Dakota for borrowing this image from him. Look how smooth this cut is all the way around there. And there's times where I will, to the point of what we were just talking about, is not hitting the tooth. I can actually, on a lighter power level, go right along that margin. And if anything, it's going to smooth the margin, but will very nicely smooth the way that that tissue and almost festoon that away. Kind of zooming in there, look how clean that is. No question, I'm going to get a good digital scan on that. All right. Uh, Quick question back to the zirconia crown. It doesn't absorb the energy. It says basically, how does it cut? What we feel like is that what's actually happening, like if you threw a baseball at a window and it didn't blow the window out, just kind of fractured it into, like kind of spider fractured it like a spider web. That's what it does to zirconia. And we think it's because sort of the traditional properties of zirconia is that it doesn't absorb energy very well. It doesn't disperse energy. So I think it's like we're almost overloading the system and then it just cracks. It does stay bonded, but then what you can do is you go in there and you just kind of hit that bond with a handpiece and pop the sides off. So the joke that we have is instead of using 10 burrs to cut a zirconia crown off, you only need half the life of one burr, right? So thanks, Chris, for that question. Okay, so let's get into some implant stuff that you guys might see. Whether you're doing implant surgery or not, if you're restoring it, this is great because you can actually do part of the first stage implant surgery. Like I'll use my laser to do a crestal incision and do for the implant placement, do the initial punch cut through the cortical bone with the laser. I'm not doing the osteotomy with the laser, but I'm doing the initial punch cut that eases off um, some of the initial pressure that I have to do on that first twist drill to even get it through the cortical bone. So boom, laser punches the hole, kind of like the round burr used to be. You're not skittering that thing across there, and then you're just dropping right in. In this case, this is Tim's case again, where he did a little sculpture, exposed that implant, placed densipliced Sirona scan body on that, and then placed a healing abutment for healing while the restoration was being designed and fabricated. Um, all day long with this, right? Now, let's say in this case, this is a case I had where um, here this patient comes back after a two-stage implant, and I'm going to skip forward through this just for time because we're kind of getting to the end of our hour here, but this is actually a 6.5 millimeter diameter abutment that is buried. So we did it as an immediate extraction, took the tooth out, implant goes in, and you're just starting to see the little hex screw hole right in there. Jumping forward for time, you can kind of see where we're really kind of starting to expose that out. But the main thing with the laser is now, even if you don't have a buried healing abutment, you have the ability to sculpt that emergence profile so your implant doesn't look like an orange on a toothpick, right? You can actually sculpt that away. And then again, for time, I'll just kind of jump forward here. So now the healing abutment's finally out, and I'm shaping that tissue for a nice anatomic emergence profile off the head of that implant that in this case is pretty deep down in there. And then we take our scan post, we get a digital impression, and then later that morning we go ahead and deliver that crown, and it cups right into that shape that we made. You see there's a little pressure, a little blanching there that's designed to kind of help cup that in there. The subgingival surface of that Emax abutment is basically polished but not glazed, so that it basically you'll actually get hemidesmosomal attachment of that tissue as it heals to that Emax. It's amazing, right? And this is the question, going back to the beginning, if this is your practice and you see that, what do I do, right? Am I sending that back to the surgeon to fix it? Maybe. Or what if you get a broken implant? This is, by the way, a case for Josh Weintraub on the East Coast. He had this happen where the implant gets loose, gets all this tissue herniated in. Well, this is safe to cut around, right? So as you go through there, if I'm glancing to the side of that metal, I'm not going to heat or arc or spark that implant. I can clean that up all day long. Again, how were we handling this before? We'd be like, oh, shoot, I guess you got to go back to the surgeon versus you have a tool that can do it. Sculpting back for an operculectomy. Easy, right? You just pointed at it just like some of those other cases I showed you, and it's absolutely going to cut it. So wanted to show you one case really quick of the case of a gummy smile. Again, I want to be sensitive to the time. I appreciate all you being here. Gummy smile, this is kind of traditional flap surgery. This is 6 weeks after surgery. This still looks terrible. She, years later, had it done with erbium laser. This is 3 weeks after surgery, still looking terrible. And so she comes back, and we're going to do this this surgery here where I'm using, again, long axis of the tooth, using that to kind of clean back some of that tissue. Then we get into actually removing some of the tissue over that, kind of reshaping that, right? We eventually have all that sculpted away, and then basically I'll fill that in with composite, and then here's 4 days after surgery. Compare this with the other ones. She's already looking much better. And here's 1 week after surgery. All right, 1 week. This is the kind. So was she numb? We used a little topical. That's it. Right. And then filled that gap in with a little composite. And then here's how she actually heals up from that. So this is why we're so excited for this. I'm going to get to some of the questions in the last 5-6 minutes we have, but just to throw a couple more things out there. You remember that video of the collagen contracting? There's a newer handpiece that It's a non-ablative cut. It doesn't cut like you saw. There's no de-epithelialization. It's just basically shrinking collagen. And basically it helps to tent up that whereas a lot of snoring is because that palate is sort of falling, the uvula is sort of falling back. You see this person's opening, you could hardly even see their throat. So 15 minutes of chair time, one treatment time, and you're causing the palate to shrink up and actually contract and pull off the tongue. So you're improving airway. This is not treating sleep apnea. This is treating snoring and airway for that, but you're improving snoring just simply based on that. So incredible application for that. Here's what's coming, and this is for perio. Now, I'm already using the traditional contra angle to do traditional pocket reduction surgery. Flap it with the laser, clean up calculus with the laser, reshape bone with the laser, remove granulation tissue with the laser. Just even degranulating takes what would be 45 to 50 minutes of scraping into 4 or 5 minutes of ablation. So it's incredibly efficient. Basically, here's the big idea is that you're able to now use this handpiece here with this tip. The tip looks like a hollow perioprobe, and it's used to treat moderate to severe periodontitis, periimplantitis. You could use it for some crown lengthening, but here's the big idea is you clean out that pocket, detoxify it, and then eventually you get basically better attachment gain. They have done a ton of homework on this study. This is actually histological studies where they show, and I'm kind of burning through this fast because and here's what we'll do. We'll talk to the Viva Learning team about doing a perio only because there's so much research now where they're showing actually new bone clinical attachment gain being formed from the treatment of this. So it's incredible. And so basically, again, once again, this opens up the door to all these new procedures that you are currently potentially not doing or becoming more efficient doing it. So again, I hope we've kind of shown that it's one of the things that we're definitely doing is being able to be more efficient, have new patient flow, stuff we never did before, and on and on. So thank you, everybody. Let's get to some of the last questions. And like I said, we'll see if we could do so just so everyone knows, this is part of something where we will do all day programs on. And like literally this is an 8-hour class and I'm just trying to give you just a tease of what so many things, but we have an advanced perio class that we teach. That class, including some of the stuff you just saw in Perio Guide, is a 3-hour class. So more is coming. I'm excited to share it with you. But just to get to these last couple of questions for tonight, do you have an issue with black triangles with anterior gingival sculpting? Yes, you have. Bruce, great question because you can't ablate away. You do want to be aware of that. If you're doing actual tissue sculpting, you kind of have to have in your plan whether or not you're going to do like a technique where you can add a little composite in there. If they're already deficient, I'm not lasering that. Again, in this case, we're sculpting, but you are reducing. The benefit is faster healing and all these things, better cutting. But you also have what happens is there's no, you cut with a diode and you get sort of this cooking effect. Diode's cutting with heat, right? And it's like taking a hot poker out of a fireplace and it's red hot and then you cut tissue with that. So you get thermal effects that go into the tissue, so you get an unpredictable level of healing. Well, when I'm sculpting with this, if they already have a black triangle, Bruce, to your point, I'm not sculpting to make that worse. But I don't worry about if I'm already not creating a black triangle, I'm just doing a nice tissue sculpting like that case with the Sharpie that you saw. That I don't worry that that's going to be 3 millimeters different from the healing because maybe I kept the diode laser too long at one particular point. Super easy to just basically have that level of control. And then wherever you cut it to, that's where it stays. And it won't create black triangles by doing that. So pretty awesome with that. quick question is a hygienist allowed to use the laser for removing calculus? Technically, it probably depends on your state, but the short answer is no. We use this more for, for subgingival calculus for hygienists, we'll do Cavitron and stuff like that. This would be in the case of parasurgery, which is then something I'm doing. It's technically FDA controlled class 4 laser, which means it cuts. That's different from, detoxifying a pocket with an unactivated diode tip, for example. So, well, hey, thanks everybody. There should be some follow-up links there for you, some questions for you on just to do the normal CE quiz. I tried to make them really simple, right? But it's been a pleasure to be able to spend an evening, an afternoon with you all. Looking forward to the next one. Keep an eye out. I think we'll talk to the team, but maybe we'll do a Perry one next and show you even more. I have hours and hours and hours of clinical content to share with you all. So looking forward to getting together again. Until then, best of luck in your practice and hope you have a great rest of the night.